Good afternoon, everyone, and welcome to our Protect Our Province COVID-19 briefing for Alberta on September 17th, 2021. We are live streaming from the traditional and ancestral territory of many peoples. We are grateful to live and work in Alberta, a province on the traditional territory of 48 different First Nations and the unceded homeland of the Métis Nation. Today's conversation is being shared in ASL. To ensure access to completely accurate information, closed captioning will be uploaded after the live stream is complete. This conversation for the public is being shared live on YouTube, Facebook, and Twitter. We are hopeful that this will increase the accessibility of our briefings for all Albertans. The Protect Our Province COVID-19 briefing is a regular panel of doctors and experts. We will endeavour to bring timely, accurate updates on the COVID-19 crisis in Alberta and take questions from the media. The views of our panelists are their own and do not represent any institutions they may be affiliated with. We have collectively gathered here as concerned Albertans attempting to ensure that everyone in the province has access to as much information concerning COVID-19 in Alberta as possible. Today we are going to divert from our standard format to look at three very important topics impacting Albertans. We always endeavour to hear the current concerns of Albertans and respond as best we can. Today's briefing will not just have one main focal point. It will explore three interconnected but distinct areas we are hearing you would like prioritized: triage, transportation of patients both within and beyond our health zones, and surgical cancellations. We value providing reliable information, and we will arrange a more in-depth panel on these topics in the future if Albertans feel it is needed. We will begin today with some presentations and discussions on triage and transport, after which we will look at surgical cancellations and hear from a surgeon and a couple of patients around the realities facing Albertans in need of surgical interventions.
Thank you, everyone, for joining us. I would like to bring Dr. Schwartz into the conversation to start things off with an update on COVID-19 in Alberta. Dr. Schwartz.
Okay, so thank you so much, Michelle. So we're not going to delve too much into today's numbers because we haven't had the opportunity to incorporate them just yet, as they were just released. But I'm going to, first start by acknowledging that unfortunately we lost another 18 Albertans over the last 24 hours. And, this is really an unacceptable number at this stage in the pandemic, given that this was all avoidable. So my condolences to their families. What we're focusing today on is going to be ICU capacity, which is intricately intertwined with deaths. And so over the last 24 hours, we did not see an increase in the number of deaths. In fact, we saw a net drop, in ICU admissions. We saw a net drop in ICU admissions, but we saw a net increase in deaths. And we don't know the stories here, but often what will happen is as patients are not considered to be eligible for upgrade or escalation of care to the ICU, they are palliated, meaning their goals of care are shifted to keep them comfortable, to control their symptoms, and ultimately to try to address those things that are addressed without focusing on trying to keep them alive artificially using breathing machines like ventilators or more invasive measures. So I just have a few slides just to sort of outline what the issues are here. Thank you, Michelle. So this is a slide courtesy of Ziad Fazil, a member of our group, and you can check out his excellent work on Twitter. His feed is there, and this hasn't been updated today. And so, in fact, today, as I said, the ICU numbers have come down a tiny bit. But as you can see, there's been this clear exponential increase in the number of patients in ICU beds, and the orange line is the baseline ICU capacity, which is 173. So this is 173 fully staffed ICU beds, meaning they're staffed by an ICU trained nurse, an ICU trained physician, a respiratory therapist, etc. Once we get above that line, then we're going into surge capacity, and the maximum surge capacity is you can see it's creeping up there. It's the yellow line. And so it's to some degree a shifting target, but right now it's maxed out at 312. And you can see that we're really flirting with that yellow line much closer than we would like. According to this projection, it'll be less than a week before we are really exceeding that line, and of course that is catastrophic. Next slide, please. So just to give you an idea of how grim this is, I certainly couldn't say it better than Dr. Ron Briggsbaugh, who has very different lived experiences. So what he said in a CBC article today is that he's been to war 10 times in his career, 5 times to Afghanistan, and he's never been as exasperated as he is right now in a major tertiary care Canadian hospital. He works at the University of Alberta Hospital as an ICU physician. Next slide, please. Or next slide, please. So this was a tweet yesterday from Alberta Health Services, and this was really, really jarring for me. Not to see this scene, because we've been seeing this in other stages of the pandemic, other waves, but to have AHS tweet this out really was remarkable, and it really is, to me, an SOS that they're sending out. It's a cry for help. They, have let down the facade, and they truly want everybody, all Albertans, to see how dire the situation is, so that hopefully we can help them out by changing our behavior and getting vaccinated. So what we're seeing here is 2 patients in an ICU room. So ICU rooms are designed for 1 patient each. They are typically looked after by 1 nurse dedicated to that 1 patient. And so when we talk about surge capacity, this is how surge beds are created. Extra beds are smushed in with the first, or sometimes the ICU spills over onto other wards, and other sites of the hospital are converted into ICUs, which has its own set of challenges. So if you look closely, so both of these patients are prone. We call this adult tummy time. Basically, patients, when they're on their tummies, they have better oxygenation, better oxygen exchange across their lungs. And so this is something that's frequently done. But as Nurse Ellie pointed out on Monday, this is really an intensive exercise to flip people over. They've got a breathing tube down in their airways. They have, usually 4 or 5 or more IV cannulas that are hooked up to different machines. And so it really isn't something that you can just, flip a patient over. This is something that requires very skilled individuals working as a team to carefully turn the patient over and secure all of those airways, all those cannula, to make sure that they don't get yanked out. Now, just look at the amount of space that is between these beds and around these beds. And if you can just go to the next slide, please. So this was a comment from a colleague of mine in the States. Good luck running a code in that room. And so next slide, please. So this is a picture of a code. Both of these photos, I should point out, are by Heather Patterson, who's an emergency doctor, who has taken a sabbatical year to photograph and capture the pandemic. So she's gotten these really amazing intimate photos that have been released in conjunction with AHS. So this is an example of a code. I don't know the specifics of this patient, but you can look at the number of individuals that are involved. In this case, I count 9 individuals. And, it really is something that you need different people switching off doing chest compressions. You have a respiratory therapist at the head of the bed. You have different nurses that are placing IV cannula or that are pushing IV medications. You have another physician or other team leader who is directing the code. You have somebody else who's recording things. So this really is a team affair. And if you just go to the next slide, please. So just a reminder of the space that we're dealing with. This is, obviously not optimally set up for that sort of scenario. And so when I talk about, that these surge beds are not set up to provide the same standard of care that Albertans deserve and that we are accustomed to, this is what I mean. This is just one example. And to be fair, Dr. Verna Yu has stressed, these are not normal ICU beds. And so this is a glimpse, a rare glimpse that AHS has provided into exactly what we're talking about. So how do we deal with this when we are getting right up to that surge bed capacity? There's three major ways that have been identified. The first is to decrease the influx of patients that are coming in after surgical procedures. Really complicated surgeries require a stay in the OR. So those patients now are not going there because the surgeries have been canceled. In addition, this frees up staffing and space from the canceled OR. So the OR nurses, the anesthesiologists might be redeployed to the ICU. And in addition, those OR rooms might be converted into makeshift ICUs. The second is that has been highlighted as a potential strategy by Alberta Health is to transport patients out of province. Now we know Idaho is getting slammed with COVID-19. So is Montana, and the Idaho patients are spilling over into Montana. So we really aren't going to get a lot of assistance from our neighbors to the south. BC has already said they're not going to be able to accept us. Saskatchewan is in a similar situation to us and said they can't take any patients. We know that Manitoba is 50 patients already over the ICU census, meaning they're already past, they're into surge capacity as well. So they're not going to be taking any ICU patients. So we're looking at Ontario or further. And so Dr. Buchanan is going to talk about some of those challenges of, what does that mean logistically to transport a patient that's critically ill, very, very unstable, all the way to Ontario or further. And then the third option is that we have to limit which patients get access to the ICU. And so this is the infamous triage protocol, which Dr. Bakshi is going to dive into in discussion with Dr. Buchanan. So with no further ado, I just wanted to set up the conversation today, give a little insight in exactly what we're talking about, and I'm going to hand it off to my esteemed panelists.
Thanks, Dr. Schwartz. So I'm going to be talking a little bit about the critical care protocol. And before I get into the triage protocol, that, it is publicly available on the Alberta Health website for those that are interested in looking at it. There is an executive summary as well that provides a little bit of the background on how the protocol was developed. And I wanted to also highlight that this critical care triage protocol was not developed specifically for this pandemic. It is a protocol that's been developed by Alberta Health Services for any instance in which we have critical care capacity concerns, issues, and we have to go into this protocol. So that's a very important point to note, that this was not created specifically for COVID-19, although it was created during a time where we felt we may require it for this pandemic. Firstly, I would like to acknowledge how morally distressing and devastating it is to even bring up the idea of critical care triage in daily discussion. As healthcare providers, we are faced with difficult decisions all the time, but rarely, if ever, are these decisions thrust upon us due to external factors such as resources, as we are seeing in this pandemic. As an Albertan, I know how scary it is to hear that there may not be space for you, for your loved ones, your children, especially if we need to enact this triage protocol. So first and foremost, I want to reassure Albertans and healthcare workers that AHS, operations, physicians, are doing everything humanly possible to avoid this triage by increasing personnel, supplies, space. That means that we are changing ICU footprints in hospital spaces, just as Dr. Schwartz mentioned, finding non-traditional spaces to place ICU beds. It means calling on physicians and nurses from other areas of healthcare and other provinces to assist with staffing. It means calling on our provincial neighbors to accept patients in the ICU, which Dr. Buchanan will speak to a little bit later. The behind-the-scenes work that is going on is a minute-to-minute, hour-to-hour basis, and it is incredible. And I assure you that this is currently an all hands on deck scenario to be able to avoid this protocol from ever having to be utilized. All of that being said, we understand that this protocol is now in the public space and that we are talking about it. And in full transparency, it is being discussed in physician groups as well. We all need to understand this protocol so that in the event that we do need to utilize it, we are well prepared and we are able to make decisions in a rational manner if possible. Again, not invalidating the moral distress around this, but in a high stress situation, we want to make sure that we are prepared. I'm also going to quickly talk about some of the concerns and questions that I've been seeing around social media and that I've been hearing with conversations with colleagues and other Albertans. The critical care triage protocol provides a framework that gives physician an unbiased, comprehensive workflow to follow. It was created over a 2-year period with a wide range of experts, nurses, physicians, ethicists, legal, based on evidence-based data from worldwide jurisdictions, clinical scoring mechanisms that have been used in the intensive care units for many years. Within this protocol, there are multiple levels and layers of checks and balances, and these are in place to ensure that no physician is tasked with making these decisions on the fly in a high-stress situation. There are triage protocol teams that are going to be developed, and there will be point-of-care triage teams that you will see in the hospital and the rural settings, no matter where the patient may be. All of the education and training required to understand this protocol is starting to happen. We're making sure that everybody is understanding of what this protocol looks like. But as I said, we are doing everything humanly possible to avoid having to ever enact this protocol. One of the big questions or concerns that I've been seeing, and many of you may be thinking this or hearing this, is did we take vaccination status into account when creating this protocol? And it's my hope that at some point in the next couple of days or weeks, we can have a broader ethical discussion about this with some clinical ethicists on this channel. But I wanted to quickly talk about why we have not put vaccines or vaccination statuses in the triage protocol. Number one, in general, as any physician or healthcare provider knows, we treat the patient that's in front of us, regardless of what their choices have been in their life and what is going on. We treat the patient in front of us. Whatever clinical scenario they're going through, that is what we treat. It is also very dangerous to make assumptions about patients who may not be vaccinated. We don't know why they're not vaccinated. We don't know if it's lack of access to the vaccination, if it's multiple barriers to facilitate getting the vaccine. Is it an anti-vaxxer? We don't know at the moment that we're seeing these patients. And at the moment that we're seeing these patients, we are simply there to help them try to recover through whatever they're going through. Nobody benefits when a physician is making a snap moral judgment about a patient, and that is true for any scenario that we're dealing with. So to answer that piece of concern that may be coming up, there's no plan to put vaccination status into the triage protocol. The protocol is a very objective tool that allows physicians to enter patient information into there based on what various conditions they may have, and allows for an objective decision to be made. That does not underscore the moral distress that all of us will be facing if this is enacted. From the ICU physicians who have to use this protocol to make a decision if they can accept patients into the ICU, to the medicine ward physicians who will be seeing and caring for these patients who are not able to be put into the ICU, to the family members who are going to be receiving the news that their loved one has been deemed not able to take ICU care, and to everybody that may be affected in the hospital that is involved in this process. So we certainly are very, very hopeful that we do not have to get to this protocol, but I want to assure Albertans that all the physicians and everybody that may be involved in this is doing what they can to prevent that, and also learning how this may work in case we need to do it. And with that, I'll hand it over to Dr. Buchanan.
Yeah, so, I think, just for Dr. Bakshi, do you want me to talk about transport or talk a little bit more about triage?
Either which one that you're feeling, Dr. Buchanan. If there's anything that you would like to add to the triage conversation, please feel free to. But we have been receiving a lot of questions around what it looks like to transfer patients both within our health zones and beyond our health zones, and the sustainability of that, and how that even mechanically can work given the distances
Yes.
that we're talking about?
Yeah. Okay. I think Dr. Bakshi answered the pandemic triage protocols and concerns well. So I'll go into transport. So I do critical care at the University of Alberta Hospital ICU, and I work for STARS or ambulance, and I deal a lot with everything from helicopters to planes to ground. And I deal a lot with transportation of the critically ill. Now, in conventional times, prior to this, transport was all about getting people around Alberta. Alberta, of course, is pretty geographically separated. So we have people flying from the north, from the east, from the west, to the south, to major tertiary care hospitals like in Edmonton and Calgary. But now we're kind of talking about flying people from Alberta to other provinces. Now, I just want to kind of walk you through the journey of what this looks like. So I think the first question that comes to my mind is, who do you select? And that, that has that's a very difficult area to talk about because, for example, if I took somebody who was freshly admitted from the emergency department with COVID-related respiratory failure, they can have very drastic and dramatic fluctuations in their oxygen requirements, and they can have quite unpredictable courses and changes of how they respond to therapy. In some cases, I can have somebody who's on, a few liters of oxygen by nasal prongs, and within 6 hours, they're on basically max amount of oxygen that we can possibly provide before we actually put them on a form of life support called mechanical ventilation. So, it's certainly hard to transport people with these considerations, but also there's really no family that wants their loved one to be separated from them geographically. And so that's also, it's hard on families, it's hard on patients, it's hard on healthcare providers to make these decisions. So, we're kind of left with this idea of, how do we pick? And, there's been issues before that have been highlighted in Manitoba around selection of patients, and how do you do that? So again, you ensure a degree of equality and opportunity, but also make sure that you respect patients and families' wishes as much as possible. But in this situation, we really are trying to maximize the resources locally and externally. So once a person is picked, that's kind of when selected to be transported, the question of destination comes up next. Of course, the longer you travel, the more potentially difficult it is, okay? And that may require stops or refueling and such. Hopefully be a one-trip destination, but it's possible it could be a stop for refueling. But that also requires ground transport. Of course, we don't transport from the hospital to a plane. We transport from a hospital to a ground ambulance to a plane. And then on the plane, they are there. And then, of course, to get transported off the plane and carted over by ground to another hospital. And so each time the patient gets transferred, there is a particular challenge. So going from a hospital to the ambulance, for example, there's always potential for risk there, especially if someone is unstable or becomes unstable in transport. Those are all concerns that get highlighted whenever there's a shift of care, going from the hospital to the emergency medical services workers, or from EMS to the aeromedical crew that are on the plane. And each of these teams are highly trained. There's no question. Our EMS providers, practitioners